Today's webinar is on pelvic floor rehabilitation and the reimbursement of such in the U.S. market. So just a little bit about me. I'm your moderator today. My name is Deb Kurtz. I'm with Labary, and I serve in the capacity as being a product manager for our Urostim device, which is Labary's pelvic floor rehab system. So it's probably no surprise then that the bulk of the folks on the call today are interested in learning about reimbursement and coding. And imagine that we have an expert with us today who fits that bill perfectly. So this is the official start to our webinar. So we'll be talking today about reimbursement from the USA perspective for pelvic floor rehabilitation. And so what makes then a whole lot of sense is for us to talk about the amazing expert that is about to deliver this information to you in a moment. But first, I do need to let you know that Labary has asked Mark Painter on behalf of his organization to present this information. And so when you get the handouts at the end of this week, you'll see that you'll be able to read this disclaimer. So we want to make sure that everybody knows Mark is the expert here. And now I'm going to tell you about why he's such an expert. So as you can see here, Mark has a lot of initials after his name. And what makes him such a well-suited expert speaker to present to us today is that he has multiple roles in the area of reimbursement. So for starters, as you can see, he's the managing partner of PRS, and he's also in charge of reimbursement and coding for physician reimbursement systems, which is also known as PRS. So he founded PRS quite some time ago, right? But he also serves our industry in multiple capacities. So he assists with coding and reimbursement information with medical practices. He serves as an expert legal witness. He serves industry participants such as Labary and other medical device companies. So you can see he has a breadth of experience in the area of reimbursement and in coding. And that's why we're so fortunate to have him sharing his wisdom with us today. So what I'd like to do now is turn the floor over to Mark and ask him to please share your wisdom with us on pelvic floor reimbursement information. And we are waiting with bated breath. Thank you, and take it away, Mark.
Very good. Well, thank you very much for that kind introduction, and also for dating me with pointing out how long I founded this. So it has been a while that we've been in this particular spot. So I'm happy to work with you all today. Now we'll get started on all this. So I did want to let you know that I am going to be using some information from CPT today. And what we're really going to go over today is the documentation and the coding related to the pelvic floor rehabilitation journey for the patient. Again, a reminder, they are going to provide some handouts. Then handouts will include these slides. And so we will go through those, and I will take questions, as Deb mentioned, at the end of the program through the question box. So without further ado, we'll jump into the next thing. So I wanted to start off, I got to get used to the delay, start off with a scenario. So this is a typical patient, 55-year-old female with a loss of urine with cough, sneeze, laugh, or strain, which began after her fourth delivery and it's getting worse. Abdomen has no abnormalities. Her pelvic exam has little mild prolapse, no rectocele or cystocele. Muscle tone is average, sensation is normal, and her UA is normal, as is her PVR. And so from that, we're moving forward in our treatment program with some diagnostic tests with Urodynamics and a cysto. She's trying to avoid prescriptions and would like to instead consider pelvic floor or biofeedback. And of course, we need the results back before it goes forward. So when we look at this as a typical patient, the first thing we want to do is make sure that we've coded correctly for that evaluation and management encounter. So when we tear this down to the actual billing and coding rules, we would look at this patient and the documentation as a patient who has a chronic condition. She's had this problem for well over a year and looks like she's going to keep having this problem. and it's clearly getting worse. So it's chronic with exacerbation, which puts our presenting problem at a moderate risk or a level 4. Our data right now, we've got a UA that was reviewed. We've ordered an ultrasound, which we can count as data. But we haven't actually added in all the urodynamics because we're going to get paid for those. And then we've got the option to look at risk, but the major surgery with risk category or a minor surgery without risk is actually categorized based on the endoscope or the cystoscopy, because a diagnostic endoscopy does give us a level 4. So 2 out of 3 gives us a level 4 for that particular encounter based on the patient's presentation and the decisions that were made. But this year, and hopefully all of you are well aware, and that would be a typical bill for most folks, but this year we've had a new code that was added, so we want to make sure we add that to the list, and that's code G2211. So hopefully all of you are using this. I've been talking about G2211 in various programs and in our podcasts and all of this, and we've still had a lot of questions about this. But I think one of our major problems with G2211 in urology is that people have yet to develop the real habits to actually add this code to each and every E&M encounter where it is appropriate. So I just wanted to go over really quickly where that is and encourage you to do that. So basically the G2211 should be reported if an E&M code is billed. Now that has to be an office visit code. So you can't use this for the hospital setting. It needs to be an office visit, either a new or an established patient. And it is for those cases in urology where the urology practice will be managing a single complex condition that the urology group is going to be at the center of care for. So that would be anything like BPH or prostate cancer, bladder cancer, incontinence, of course, as we've looked at here, and a renal cyst, a recurrent UTI, recurrent stones, those things that, again, are the patient's going to be reliant upon the urologist and urology care, and you as a group are going to be providing that service. So when I keep mentioning it as a group, what this would mean is that if the physician were the first person to see this patient and put them through the system, maybe they do the second visit with urodynamics, and then after that, they're followed by an APP. All of those visits could have an attached or appended G2211, even though they weren't necessarily with the same individual provider within that group. So that's one thing. Now, we're not supposed to use the G2211 for any of your encounters for disease states that are not going to be longer term or managed by the group, something that you don't need to have a longer term relationship with that patient. So those might be things like an initial visit for flank pain, or an initial visit for gross hematuria, or even a second opinion for somebody who has incontinence. So if we don't know that they're coming back, we can't use that G2211. If we do know they're coming back, we can. We also can't use the G2211 for E&M visits in which we need to use a modifier 25 to get paid. And that would happen on the urodynamics visit, obviously. If we're doing an E&M on the same date as the urodynamics, we'd need a 25 to get paid for that E&M visit, so we couldn't use the G2211. Now, interestingly, Medicare made a big point that this is about the relationship with the patient and the physician or the group's relationship with the patient. So for those patients that you are following for, let's say, incontinence, and maybe in between some of their treatments for their incontinence or while they're dealing with their incontinence treatments, they have a complaint that normally fits into that second category of a visit that isn't for a long-term problem, something like a UTI that occurs. We can still use the G2211 for those visits because we have that relationship built around that other long-term diagnosis. So you do want to be able to charge for that anytime you have that long-term relationship, even though it is not necessarily that problem that is the focus of that particular visit. Now, that also means that on your diagnosis coding that you do want to include with the G2211 that longer term diagnosis. That's the reason you have that long-term relationship. So hopefully all of you are doing that routinely. Now, from a percentage side of the equation, I would encourage you to take a look at how often you're using the G2211. We've been doing a lot of studies with our revenue cycle management clients, our clients that we bill for, and trying to give them the feedback that they need to encourage this to be used, because in reality, it doesn't require any extra work. It just requires that your documentation actually support a return visit. So you can get paid an extra $16 or so per visit, depending on where you are, with very little additional documentation. So you want to really make sure you're using it every time you can. So I've heard, from a projection standpoint, Medicare thought that across Medicare, we would see a G2211 reported with 57% of your E&M codes. Now, when you adjust that for some of our specialties like radiation oncology or orthopedics that really don't have the ability to charge that G2211 for the long-term relationships, and you consider the number of colds and things and people that don't have long-term conditions seeing primary care, you can see that some of our specialties are going to be higher than that 57%. And I think urology is going to be one of them. Now, not every subspecialty in urology will have this, but you're going to have some of your subspecialties within urology that are using it, upwards of 70 to 80% of the time. Some people think as high as 90% of your E&M codes will see a G2211. So do keep an eye on that and use that appropriately for your patients. Now, some of the additional things we want to talk about today when we're talking about that journey for that patient who's going through pelvic floor rehabilitation. One is Modifier 25. Now, Modifier 25 is the most utilized and most misused modifier that we have in coding and reimbursement. And I know that a number of you have, especially in the billing and coding side, have struggled with the amount of medical record requests, appeals, and training with your clinical staff to get them to document well enough, to report well enough, and to then turn around and fight those battles that you need to with the payers. And we actually ran into the fact that we're actually submitting documentation prior to payment for United Healthcare for about 35% of our claims that are going in for a bunch of our physician groups around the country, and which is a big number to go through, which really means that documentation is going to be reviewed. And that's the assumption that everybody needs to take relative to their documentation and the coding that you're using to report that. So looking in at the definition of Modifier 25, which is a significant separately identifiable E&M service on the same day as the procedure, what we really need from a documentation standpoint is a decent separation, if you can, from any procedures or any services that are done on that day that would include an E&M service. So if you can separate it out and clearly identify the work that was done that wasn't related to the procedure as an E&M service, you're going to have a lot easier time getting those paid. And remember that a lot of the chart reviews are being done initially by computers. So as much as you can add information into your document that identifies this as significantly and separately identifiable, the easier it is to have the computer flag that for those secondary individuals who are reviewing those. Now, I did want to remind everybody of a couple of different things. So number one, for Medicare, a PVR and a Euroflow do not require that the E&M gets a 25 modifier. And this has become very important with our use of G2211. So those codes have XXX globals, and the bundling edits from NCCI do not include E&M codes. So for Medicare and all those associated Medicare plans, you should not be required to use a modifier 25 with your PVRs or your Euroflows. However, we do have some of our Medicare Advantage plans that are requiring a modifier 25 in order to get it processed by their computers. For those payers that are playing that game, I would still go ahead and use the G2211 when the E&M code was not under Medicare rules required to receive a 25 modifier. And we have found that that is getting paid even when we use that modifier 25 if it was appropriate for that particular combination of services offered. And then the last thing I wanted to mention is both in CPT and in Medicare, we are not required to have a different diagnosis on the E&M code. Now, some of your private payers, they may require that, but more importantly, those are ones that they're looking at more specifically. So if the E&M service was done for a different reason, by all means, use a different diagnosis if that is at all possible to help with the workload and dealing through the revenue cycle management process. Okay, next, I wanted to jump over into Incident 2. This has become a fairly hot topic. Of course, it's an issue because the APPs, which are becoming an increasing part of urologic care, are paid less if they're billed under their own NPI number. They're paid at 85% of what the physician is paid. So with the fact that our conversion factor has remained so low for so long, in fact, physician reimbursement is about 30 years behind when you adjust it for inflation, it's important to understand where those pennies can be had appropriately. Incident 2 is one of those areas. So as long as there is a physician in the facility in which the services are provided, and your mid-levels are providing services that are an extension of the physician, meaning it is a continuation of care for that patient under a plan of care that was established by the physician, then those services can be Incident 2 without direct face-to-face contact with the physician. That also means the flip side, of course, is that if the patient presents with a new problem, or your APP is changing the plan of care, then that no longer qualifies under the Incident 2 rules and now needs to be billed under your mid-levels that are providing those services. So you want to make sure you're paying attention. Medicare also clarified last year in April that diagnostic tests that are administered by the APP cannot be reported as Incident 2. So those will have to go underneath the APP. That is one of those encounters that doesn't necessarily change the plan of care. So visits following that may still continue to be billed incident to as long as the physician's plan of care is followed. But if a patient comes in with a new problem, or there is a major adjustment or there's an adjustment to the patient's plan of care continuing to go forward by the APP without physician-patient contact, that will need to be moved for that visit and moving forward until a physician actually has an encounter directly with the patient to the APP billing. So a couple of nuances there. And ultimately, what we have found as we've worked through this across all of our practices and with so many of you out there is that the most important group of people to understand the rules of incident to billing are your APPs. So you need to take some time and make sure that your APPs are clearly involved in and understand the rules of incident to and how to report those mechanically within your organization. Next, I wanted to move on to urodynamics testing. Now, this has been around for a long time, and of course, urodynamics testing, I hope, is routine for a lot of you, but just a quick review. Usually the base level urodynamics testing includes a CMG, either alone or with a bladder voiding pressure test, or with a bladder voiding pressure test and a urethral pressure profile study. That is the differentiation between these codes. Only one of these codes can be reported for each urodynamic visit that you do. Most folks are using the 51728, but I will tell you that with female incontinence and for men that have had previous surgeries, it's not uncommon to use the 51729. So be careful that if you've got charge sets or you're looking for prior auths or any pre-certs or anything that go in place with urodynamics testing, which isn't always required, that you do pay attention to what is going to be done based on the type of patient and make sure that medical necessity is there for the urethral pressure profile study and the documentation supports it if you're going to use the 51729 versus the 51728. Relative to the remainder of these services, the Uroflow, then the EMG, and the abdominal pressure flow and the post-void residual are all very common. The issues that we see here from a documentation standpoint and from a coding and billing standpoint actually occur relative to the Uroflow and the PVR. So number one, the Uroflow in conjunction with urodynamics really should be done prior to the urodynamics study. You are not getting a full Uroflow. Now, right now, most payers are paying for that, but it is not a natural Uroflow during a urodynamic study, and we are seeing some payers deny that. So you'll want to keep an eye on that. But appropriate documentation, if you run into that, is have the Uroflow done ahead of time and then do the PVR ahead of time so that you've got, and that gives you a good window into the patient's natural voiding patterns before they go under the urodynamic study. So sequencing can become important as the payers start to drill down a little bit on urodynamics. If you use video urodynamics, you're going to add the code for both the radiograph and for the dye, or for the injection of the dye. So those two additional codes would be used for VUDs, or video urodynamics. So you want to make sure that number one, these are reported, and number two, they're clearly documented. That's one of those things that sometimes gets skipped is the actual injection of the dye. So you want to make sure that you document that well as to what is being injected and how much. And then, of course, for any radiologic procedure, you're going to want to save the images and document well the interpretation of that in addition to the rest of the urodynamics tests that are being done. Now, we do have some folks that have, in addition to urodynamics, reported the anal rectal manometry. Now, anal rectal manometry, or 91122, is allowed by Medicare, but it does follow Medicare guidelines overall that it needs to be medically necessary. So you need to have a good reason to add anal rectal manometry with urodynamics or any of the other tests that you perform. And you want to make sure that you're paying attention to your Medicare local coverage decisions and local coverage articles. This is a very limited allowed service because it is not always required for general urodynamics. So you want to make sure you put that extra documentation in place if you are going to charge or provide the test for anal rectal manometry. Now, I already mentioned a little bit LCAs and LCDs. I should probably also mention NCDs and NCAs. LCDs and LCAs are local coverage determinations. That's the LCD, and the local coverage article, which is the LCA. And then the national version of that, the national coverage determination and the national coverage article. The national coverage articles apply to all Medicare MACs. The locals, the LCAs and LCDs, actually apply to only those jurisdictions which are listed. Now, that is something, maybe one contractor, one MAC, one Medicare administrative contractor develops the LCA or the LCD. Another MAC could adopt that same policy. So you want to look at where the jurisdiction is, and you can do that in the data set across the board. And that's where you want to look very carefully at each of the services. Now, here's a quick map of the MAC jurisdictions. So again, the MAC is a Medicare administrative contractor. You can see that Noridian and Novitas have significant parts of the country. Noridian is grouped a little bit more than Novitas or Novitas, however you'd say that. Then you've got WPS, CGS, First Coast, and NGS as your other MACs that are out there, and then a small leftover portion for Palmetto. Pay attention to those. They do change on occasion. The LCAs can change much more frequently than the LCDs or the NCDs. NCDs are very slow to change. It takes a big administrative lift for Medicare to do that. LCAs are coverage instructions and coding instructions, and those were specifically separated from LCDs so that the payers could actually adopt those fairly quickly. So again, you want to look at these issues, and again, the coverage decisions that are there, the Ds, will give you the reasoning behind the actual articles if they are associated. They give you medical reasons for why Medicare is making limitation decisions relative specific codes, and they do take time to review, but they can be changed and challenged. So this is an example of an NCD for a non-implantable pelvic floor electric stimulator. So you'll note when it has been effective and when the implementation date is. It will also have a description of what the discussion was around it and the final determinations as to what is allowed and when. And that's from a general high level standpoint. LCDs and such will have contractor information, and you can see where the jurisdiction and the states are listed under each of these. This happens to be an LCA, a local coverage article, relative to pelvic floor dysfunction and anal rectal manometry, which I put some links in to where you can get that. But this is an article that talks about when and why a particular service can be provided and how often with anal rectal manometry. And it includes a specific diagnosis list of codes that are allowed with those particular services. So, and be careful as you read those. So they group things often in these LCAs to say they may address many different CPT codes, but they will group them specifically by groups to say, okay, for group 1, these 2 codes, these are your covered diagnoses, or these are the ones that easily support medical necessity. They also could have a list of codes that do not support medical necessity. And for those codes that do not fall on the list, those are going to be ones that you put in the arguable category, that if you can justify the medical necessity and support it with documentation, Medicare may pay for it, but won't typically pay for it without a manual review by an individual and, in fact, a secondary appeal for most of those cases. Now, this is from an article from Noridian talking about biofeedback, because I want to shift a little bit to biofeedback. So when biofeedback is provided, you're supposed to use the most appropriate code, the 90901, 12, or 13, and separate billing for concurrent modalities and procedures is not appropriate. So what they're telling you here is that if you're doing biofeedback in combination with electrical stimulation and therapy exercise in the same 15 minutes, that is inappropriate. But it is not inappropriate to potentially do them sequentially. So your documentation needs to be clearly separating that time spent in doing each of those activities with your patients. Now, your physical modality coding, your 97032 and your performance tests, again, like the biofeedback, need to be separated. They shouldn't be overlapped in what they're doing. You should have focus of attention on that particular service for the amount of time that you're actually providing that service, and then move to the next one. So it needs to be sequential, and your documentation needs to support that. For your physical performance tests and measurements, you are going to need a clear written report, whereas your electrical stimulation, you can simply focus on what was done, where the electrodes were attached, how long it was done, and what the voltage was for those particular services. You also want to, of course, make sure that you're doing a good job of documenting well everything related to that patient's overall improvement, because pelvic floor stimulation and the modalities for treatment are things that are limited by time and medical necessity, typically through the number of visits that you provide. So those are things that you want to continually update the medical record to demonstrate these modalities are working, they are making improvements, so that you can continue to provide those services to those patients who are benefiting from those services. And those are things that you can argue to go beyond the standard cap of number of services that are provided. So make sure that documentation is really supporting all that you're doing in sequence, and then appropriately reported by the services that are provided. All right. So those are some of the overall things I wanted to go over today. And now, Kim, I'll open this up. For questions.
Wow, Mark, that is amazing. Thank you for that wealth of feedback on a really complex topic. So I don't know about the rest of everybody, but I'm impressed with what you have to deliver here today. So I've been manning the question board while you've been speaking, and a bunch of questions have come in. So Let's start first with a topic that we haven't really touched on today, which is telehealth, because we have two questions that came in that area. But so first I wanted to ask you about code G2211. Is that appropriate for phone visits, such that you might put it under the E&M or perhaps under the 994X codes?
Okay.
How would that work for telehealth visits?
Okay. So I'm going to separate those. So telephone only visits, which are your 994, 41, 42, and 43,
Mm-hmm.
are at this point in time considered E&M visits under Medicare. So we can use the G2211 if all the other conditions are met, in addition to the 994, 41, 42, and 43. We have been providing this. It's not included in the description of the G code, but across the country we've been using this. We've been seeing it's paid, and it is really due to the fact that under our current payment for telephone only visits, those are considered a substitute for an E&M code, so it is allowed.
Wow, thank you. So it seems like we got a couple telemedicine questions coming on here. So here's the next one. So could you do incident 2? Does that apply if the provider is doing a telehealth visit?
So the way that E&M visits are categorized right now, that the overall efforts of the physician and the service or the service of an APP and the way those services are provided, we have been seeing that they are allowing that those telehealth visits can be done incident to if they fit the standard protocol, meaning the physician is in the facility that the APP is in when the visit is provided. That one's a little bit tougher in some cases when your APPs are obviously working from home. You cannot, but they do. So you still have to have those same qualifications. But I think the overall important piece here in all of this is a telehealth visit is a urology visit. And therefore, if it follows the same pattern, right? So the service provided by that individual is under the direct supervision. Remember, that would mean the physician is in the facility and available. Then it would be allowed to be billed incident 2 as long as they are continuing to follow the plan of care. So it has to be done from the office, the doc has to be in the office, and it needs to follow the plan of care to qualify.
Excellent. Well, thank you, Mark. So another question has come in is, are there limits on the number of times a physician can report G2211 on the same patient?
There are no frequency limitations. The limitations are only those that we stated ahead of time. For those that you're not billing an E&M, if you're using a 25, or if you're not billing an E&M code. So those are the only limitations. So every time you see the patient, you can use that G221.
Great. A question about EMG and biofeedback. So can a provider bill EMG with biofeedback?
Okay, so EMG and biofeedback are two different services, and that is a focus, as you saw in the LCA from Noridian. So an EMG that's done as a diagnostic test prior to biofeedback is allowed, but there are frequency limitations on when that can be administered. So you don't need an EMG test every time that patient has biofeedback. So typically what we see is an EMG baseline diagnostic on the same date as biofeedback at visits 1, 6, and 12. So they're basically done to monitor the patient and how they're where they start and how they're progressing using biofeedback. But you cannot build that EMG with biofeedback if A, it's not medically necessary, or B, it's really part of the biofeedback, because you've got to have some loop back to the patient to actually perform biofeedback.
Understood. Oh, here's a good one. Are there any diagnostic codes being used with urodynamics that seem to have more issues than others? Sounds like this is a watch out question.
Yeah, it is. So first I'll give you a general answer to that. One general answer to that is, the payers are definitely cracking down on the use of non-specified diagnostic codes. So if you've got some situation where the ICD-10 code can be more specific to the disease state or the location of the problem, you'll want to use those. The secondary and more specific answer relative to any of your pelvic floor treatments is watch your LCDs and your LCAs. I think we showed you a list of certain things that are covered relative to EMG specifically, but there are others out there for pelvic floor exercise. So you want to watch those very carefully. And then I think every billing staff that's out there, or billing service, whatever it is, once you identify that a payer is not paying for a specific diagnostic code in that first position, you want to consider looking at the documentation and seeing if another code is more specific. You want to double check that you've followed all the payer rules through bulletins, LCDs, LCAs, to see if there's some guidance there. Run your appeals, but then loop that back to your clinical staff so they understand what is not allowed for particular payers for that process. So it's a little bit of a process of trial and error. It's a big process related to the amount of research that you do, but it's also the game of reimbursement, where you're finding out who pays what for what and making sure that's well communicated across the board so that you can focus on getting paid for those things that should be a problem, not those things that you can avoid problems with.
Thank you.
Certainly.
So I hope you've got time, because, man, we got some more questions coming in. So
Okay.
Here's a good one. Which type of biofeedback are you using, and for better results? Which ones are you seeing that offer better results?
So I'm not a physician on those on that, and so with biofeedback, I haven't had many discussions recently with groups out there that have differentiated how they're doing biofeedback. So I'd have to say I'm not the right person for that question. So that might be something I'll definitely ask around as I move forward, and maybe down the road I'll have a good opinion on that, but I don't today.
Understood. Here's a good one about length of time on electrical stimulation. So does electrical stimulation have to run the full 15 minutes, or is there an 8-minute minimum?
Yeah, so it is over half. So that 8 minutes is where
30
you want
seconds
to
over
be.
half.
Yeah. So 8 minutes definitely puts you on the other side. And that is true of the next one. So, when you go to 23 minutes, right, you're now at 2 15-minute increments. But yeah, over half gets you to that point. Now, there are some payers that we know that have asked for specific minutes, and they've done some specific prorating of that, like they do with anesthesia. But the general rule is over half of the 15 minutes.
Makes sense. Thank you.
Mm-hmm.
So this next one, I'm going to probably have to say it a couple different ways, so bear with me. So we're doing pelvic therapy, and it's being performed by a physical therapist, and can they use the initial diagnosis even if the subsequent visits do not include a specific diagnosis, but say pain or other issues are resolving? Any
Okay.
comments on that?
Yeah, so you do want to use your ICD-10 codes to tell the story, right? So as you're moving through the process of treating the patient and symptoms are resolving in that, you can look at using history of in telling those stories that they used to have that and they no longer do. But I will tell you that the unfortunate reality of our reimbursement world sometimes puts limitations on when those can be removed for the reimbursement side of the equation. So you may be required under some payer circumstances through the treatment process to use those diagnoses that were present when the plan was established. So you're treating them throughout with that diagnosis. Ideally, from ICD-10's perspective, you would remove those as the visits occurred. But that's not always the way that our reimbursement system works. So you may be using those throughout the treatment protocol. And then, of course, with those resolved, then you don't have that moving forward after you've done the initial treatment plan.
Thank you. This one, I think, circles back to our earlier conversation about biofeedback and EMG. This specific question is, can you bill biofeedback with the code 97032 for electrical stimulation?
So you can, but that documentation really needs to demonstrate the sequence, right? That biofeedback was done for 15 to 20 minutes, and then the patient was set up for electrical stimulation, and that was then performed. So they can be on the same visit, but you're probably going to see your documentation pulled for that on a routine basis. So make sure it's clear that you move from one to the next and you didn't try and do them at the same time.
Thank you for clarifying that.
Certainly.
So I have another incident 2 question. This also I have to kind of break it into some parts. So we've got an incident 2 question where one provider wants to know if she can write an extensive plan. For example, like if anticholinergics don't work, then we're going to start a beta antagonist. So she writes an extensive plan, and she wants to know, can we keep it incident 2 rather than having, say, an NPP or an advanced practitioner taking over the management secondary if the meds that initially were prescribed don't work out?
Okay. So
did I explain that right?
You did, and that's actually a great question. So the plan of care definition is just that. As long as the patient is on a plan of care established by the physician, then they should be allowed to continue to bill incident 2. Now, we've had to argue a couple of times with specificity, right? So ultimately, if you have a setup of plan that says, all right, if this doesn't work, this particular drug doesn't work, then you feel free to change to one of these other drugs. So there's a list that it gets picked from, kind of like what you asked, anticholinergic to whatever. So you've got a very broad guidance tool that goes through that. We can argue that stays within the plan of care. But there are some folks that have pushed back from the payer side that have basically said the decision as to which anticholinergic is now something that you're leaning on your mid-levels practicing licensure, their experience, and they are in fact now establishing their own plan of care by choosing the drug. So my recommendation right now is, yes, if you establish that general plan of care that really is guiding your mid-levels through the process. If this fails, use another one, but from this list or from the same category, if you will. And go ahead and do that. But know that there are some payers that are not going to let that fly because it isn't at the detailed level of if, you know, if tropicin doesn't work, switch to Myrbetriq.
Mm-hmm.
That would be a more specific plan that they would have a hard time arguing with. So the door is open for that. But as with everything, I don't think we're going to be in the black and white world of me saying, yeah, you're good to go with a general plan. I think you can do it, but you may run into some issues.
Understood. So I got a question that might not be able to get done in the time we have. So let's just see what you have to think about it, because this has to do with the sequence of coding. So this practitioner had been coding in the order of 91122, 51784, 97750, and then lastly 97032 for each pelvic floor encounter, and experiencing some pushback. Wants to know, is there a particular sequence that's wrong here, or any advice you might have?
So I'd have to understand what the problem was going back. So, a sequence of CPT codes typically affects either the level of payment that's in place. So this one's paid at 100%, 50-50-50 if there are multiple procedure directives, or potentially the modifier use that's there. But generally speaking, sequencing doesn't affect the overall coverage of things. So if the denial was for the 91122, it's not that you can move it down the list and now get the 91122 paid. So that sequencing is really not related to coverage. It's more related to payment amount. So I would suspect that it doesn't matter relative to what they're getting their pushback on, but it might.
Well, thank you for that. And I want to thank everyone for their attention today, and mostly to thank you, Mark, for sharing your expertise, giving us insights and guidance on an area that's really near and dear to all of our hearts. So I wanted to thank you on behalf of Labrie and for everyone who's been on the call today. I wish you all well. And again, my thanks to Mark and everyone at PRS for their help today. Bye for now.
Thank you. All right. Bye-bye.